I'd like to thank you for having me here again. I was here last year, and I really enjoyed the conference last year. I'm honored to come back again, and thank you for your hospitality. I've realized there's a couple things I need to do in the future, one of which is learn Spanish, as I miss way too much. And so living in South Florida is... So one of the things I need to do is learn Spanish. That's on my list of goals for the next couple years, is I need to learn Spanish so I get more out of this and communicate better. But one of the advantages and one of the things I love about practicing pediatric neurosurgery is, like, unlike the adult practice in the US, we get to do almost all of neurosurgery still. Most of the adult practice tends to subspecialize and only do cerebrovascular, only do spine. And the joy of the pediatric practice is that I get to do it all. And so I'm going to talk today a little bit about one of the things I really like, which is cerebrovascular and pediatric vascular problems, especially moya moya. We'll talk about that. And then also going to talk about, my second talk, about the thing that none of us really like to do, which is traumatic brain injury in kids. And we'll also focus on some of the minor head trauma and how we manage that and how I've had to handle it in my institution. So first we'll talk about the neurosurgical management of pediatric vascular problems. So we're going to review the main types that we treat in pediatrics, discuss different ways to approach those. I'm going to go through a few case examples, and I'm going to go a little more depth about moya moya disease and moya moya syndrome, which is one of the things that I have gotten to like to treat over the years. So a lot of the vascular problems in pediatrics, of course, overlap the adult side. We have aneurysms, we have AVMs, AV fistulas. Moya moyas happens in adult population as well. Stroke, more common in adults, but still happens in kids, more common than we think. And vena Galen, which we won't talk about much, but that is mainly a pediatric issue. We diagnose that right at birth, and that's a very complex issue, mostly endovascular management depending upon cardiac output. We won't talk about it much today, but that is a key team approach, which is one of the things that I think is really important as we manage vascular problems in kids, is it requires a team. As much as I, as a neurosurgeon, would like to go in and just tell everybody what they have to do, that's not the reality of the best care for the patient. The neurosurgeon is important for helping direct the care and helping manage things, but the endovascular practitioner is super important. Radiologist to look at things that we miss. Intensivist for both managing post-op or the patients that present with hemorrhage. And then radiation oncology over the last years has become very important for the complex AVMs. So pediatric aneurysms, very rare to just be independent in kids. I probably on average only see 3 to 6 just primary aneurysms in kids a year. MCA is the most common location, and about half of them present with hemorrhage, versus about in the adult population, about a third of them show up with hemorrhage and the rest are discovered in other means or incidentally. About half the kids show up pretty sick already with a subarachnoid hemorrhage. Most of the aneurysms that we see aren't primary. They're associated with an arteriovenous malformation or with an AV fistula. So clipping or coiling are both valid options for managing the aneurysms, but as real estate, it's all location, location, location. Is it an area we can get to easily without causing a lot of damage? If it's in the center of an AVM, we are not going to primarily clip that. We're going to coil. And the long-term considerations in pediatrics plays a role as well. Clipping lasts longer, there's less complications, coiling works, but there's a lot more follow-up that's needed. If we can clip a primary aneurysm, we do so. Last month I had a PCOM come in a 14-year-old, and it was amenable to coiling, but it also was amenable to clipping. And after a lot of discussion with our team conference, we decided to go ahead and clip it because the long-term durability of it is just better than coiling it. So as we all know, the AVMs are very dangerous, very high-pressure lesions. And in the pediatric population, they often present with hemorrhage. We do discover some incidentally with they hit their head, they're playing sports, they have a headache and we see it, but an awful lot of them do present with hemorrhage. And the first thing we do when they come in is look for high-risk features. Do they have an aneurysm? Are they a really high-flow state? So the first thing we do if they've come in ruptured, we manage both their blood pressure, keep it normal to low normal, and we get a CT angiogram as well as a CT when they first present to sort of know if we can see what we're dealing with. And if they're having signs of high ICP, I do a decompressive craniectomy right away. Take off the bone on that side, open up the dura, and I don't go after clot, I don't go after the AVM. Let it be. Give it time, define it further with an angiogram, and then once they're stable enough for angiogram, if they're able to, they embolize right there. If they're not, at least we define what we're facing and start coming up with our plan. Is this something that's amenable to surgical resection, depending upon the Spetzler-Martin grade, its location, its size, its drainage? And then something I have done now a lot I've had some very complex holohemispheric, bihemispheric, multiple different branch feeders of huge AVMs. And during my training, I saw some surgical attempts at those, and the complications are not worth it. I've actually had really good results now with a radiosurgery. Even really big ones, staged radiosurgery with different dosing at different times across large aspects of the AVM. And it takes 2 or 3 years, but they involute over time. And it really is effective. So that's sort of our backup if we can't resect it, if we can't embolize it. And a side note for the radiosurgery, if we are going to go straight to radiosurgery, we often don't embolize. Just do straight radiosurgery, because the embolization can actually increase our risk of bleeding in the short term. And so we just let the flow pattern stay the way it is and just go right to radiosurgery. So, illustrative case is a few months ago we had a 17-year-old boy come in with a ruptured AVM, posterior fossa, presented with altered mental status, severe headache. And as we all know, the normal pattern over here on the left for the artery, capillaries, veins, and on our AVMs, we lose that connection. We have a high flow pattern directly from the arteries and bypasses that pressure differential change of the capillary bed. And as we evaluated the patient who came in, we always look at our Spetzler-Martin grade, looking at the size. Is it grade 1, 2, or 3? Is it small, medium, or large? Is it an eloquent or non-eloquent brain? And is it superficial or deep drainage? And I will only operate on grade 3s or less, unless it be a very unusual 4 that's completely not eloquent, but just very large and drainage we can take care of. Just the data in the literature and then my own personal experience and observation, it's not worth most of the time operating on the really large ones. You may make the image look great, but the patient does really badly. So this is the initial angiogram on a patient who came in, and we see there on the left the about 3 centimeter nidus of the AVM, superficial drainage, and a non-eloquent cerebellum. So we met as a team, talked about it. This is the lateral projection, and decided to proceed with embolization. So we did Dr. Obuje, you'll see a picture of him in a little bit. He's very talented endovascular, was able to navigate his microcatheter directly into the AVM. Sweet. There we go. And we can see it going into the AVM and the largest draining vein. And then he was able to then embolize it with onyx. And here we see on the skull x-ray the onyx in the AVM, and then the lateral projection of the onyx. And then after that, we went in and resected it. It's interesting, even with embolization, where it looks right on the angiogram that you've taken away all the blood flow, there is always still a little bit of blood flow around the AVM, which I think is a reflection in literature that just embolization alone doesn't prevent recurrence long term. Most AVMs, if you give them enough time, and only embolization will recur in some fashion. And so that's why when we can, embolization and then surgical resection. And here is the angiogram after the embolization, and there's no longer any flow we can see on the angiogram, yet intraoperatively there's still a little bit of flow. You know, very controllable, much less, but you still see some microflow from sort of microvessels around it and some flow in and around it. And so this is, on the left is Dr. Obuje, who's our endovascularist, very skilled, and the patient and his dad. And so he ended up doing very well. He had to recover in some rehab from the cerebellar hemorrhage, but ended up doing very, very well. The next one I want to talk about is a 6-year-old boy who came in with a ruptured arteriovenous fistula that had an associated aneurysm. And the aneurysm is actually what bled for this fistula. And so for these peel AV fistulas, it's on the surface in the peel area, and again, you have a direct connection between the arteries and the veins. And they're actually very manageable. Sometimes we can just do a small surgery on the surface and clip them. Sometimes we can embolize them, but especially in the setting of the high-risk aneurysm, that's the first thing we dealt with. And so, again, one that's amenable in a kid, we will go in and clip if it's an accessible location. But if it's a location that's difficult or we're going to cause more damage, that's where coming in endovascular with the coils is really useful. So this is a projection from the angiogram, and we can see the large aneurysm there. And could be clippable, but you have to dissect a significant amount of brain to get there, or it was very amenable, given the size of its neck, to put in coils. And so first we did the angiogram and just sort of defined the aneurysm. And here's his lateral projection. And then Norm was able to navigate his catheter directly into the aneurysm itself, and you can see that connection there for the fistula. And then he was able to navigate the microcatheter all the way into it and start putting in the coils. As someone who only does the open and I don't do endovascular, I always find what they can do fascinating with putting the coils through these tiny vessels. You kind of see them just migrate in. And they're platinum and they're very effective at thrombosis and then stopping the flow to the aneurysm, and in this case it also stopped the flow to the fistula itself. So it treated the aneurysm and treated the fistula. And here we can see the angiogram after, where we no longer see the connection of the fistula coming out. And you can see the coils move just from the pulsating brain. And here he is after his treatment. He did really, really well. And that's actually one of the joys of treating the pediatric population, is the patients do so much better than the adult population. Even if they're pretty obtunded or difficult, the neuroplasticity of the developing brain makes us look better than we are, and I appreciate that. So the other thing I want to talk about today for vascular issues is Moyamoya disease. And it's pretty rare, especially in most parts of the world. In Japan, it's much more common. That's where it was defined. Exactly why primary Moyamoya disease is unknown. And it's characterized by stenosis of the vessels around the circle of Willis. And it can be bilateral, it can be unilateral. Bilateral is how it was first defined, but I've actually seen quite a few kids where it was unilateral. And you slowly stenose off the big vessels coming off the carotid in the circle of Willis. And the name comes from the Japanese word for puff of smoke, which is, there was a descriptor of the angiograms they saw when they first were doing these, that they looked like smoky, like a smoke collection coming off a fire. And that's how the disease was defined. So there's no medical treatment that we know that reverses it or stops it. The aspirin, I think, actually is an important thing to do. I am one of the some that believes it does reduce incidence of microemboli. So all my kids who come in with moyamoya, we immediately start them on aspirin. If we do surgery, we would do surgery while they're on aspirin. And it does really seem to decrease the incidence of strokes. The other part of that is, I always tell the parents they have to stay hydrated. Aspirin and hydration really help decrease the amount of strokes that occur as they're getting revascularization. And for the right patients that don't have good collaterals, surgery is the mainstay of treatment. So I think there's a subpopulation of moyamoya that it happens very, very gradually. And as it's happened gradually, the brain's able to recruit vascularization and neovascularization from the outside, and they do well, they don't have strokes. eventually they have good external flow. But for the ones where it is happening faster and the stenosis happening faster, those are the ones that develop significant strokes. And I've seen quite a few of those. And that's where doing a direct or indirect bypass can be very effective in treating them long term. So the other component of moyamoya is that we have the primary disease, but we also have what we now call the moyamoya syndrome. And so they get the angiographic appearance of moyamoya, they get the puff of smoke, they get the stenotic vessels of the circle Willis, but they have what we now know as known risk factors for moyamoya. And so that's the separate from moyamoya disease, the moyamoya syndrome. And here on the left, we see there's a lot of different potential causes of moyamoya syndrome. And sickle cell disease is the biggest cause I see in my practice. I'm following over 100 kids that have moyamoya syndrome from sickle cell. And it's been somewhat controversial. Do we observe these kids? Do we operate on them? And the consensus is becoming, with proper treatment of their sickle cell, they don't need a bypass. So a few years, about 8-10 years ago, we did quite a few bypasses on them. And now we've gotten to the point where if they get their monthly blood transfusions, stay hydrated, take aspirin, it seems to stabilize and not progress as we follow them with MRAs, CTAs, and angiogram. Another growing cause that I have seen quite significant lately is radiation as a cause of moyamoya syndrome. I have quite a few kids who've had craniopharyngiomas that were partly resected and then got proton beam or stereotactic radiosurgery. And those kids, some of them will get delayed moyamoya. And so some of those we have operated on if it's becoming progressive. Other ones, if it's very slow, we've just observed and kept them on aspirin. So this is an example from one of Michael Scott's papers of in A, we see more of a standard angiogram. We see early moyamoya in B. We see C, we see the lenticular arteries proliferating for collaterals. And then we see the puff of smoke and a lot of loss of vessels on D. So for the surgical approach to this, there's been several different surgical approaches that have been suggested for treating moyamoya that are used. There's generally is into two different groups, direct or indirect. There's a couple indirect ways, but direct revascularization is a direct STA to MCA bypass. And so that's used more in the adults, and that's very effective in adults. For a lot of the pediatric population, their vessels are just too small to make that very effective. And so most people who treat moyamoya surgically have gone to either EDAMS or EDAS. I personally do the EDAS, which is the encephalodural arteriosynostosis, versus the encephalodural arteriomyosynostosis. For the EDAMS, they actually take some of the temporalis muscle and put that on the brain as well to create neovascularization. For the EDAS, we actually take the STA artery, keep it in continuity, and put that directly on the PL surface, as well as flip the dura. With the direct bypass, you get increased blood supply right away. There's a risk of it clotting off early on, and again, if the vessels are too small, it's not very effective. The indirect one, using the peds, it's not immediate. And so this is where there's a risk of stroke at the time of surgery that goes up. So if they drop their blood pressure, if they get dehydrated, a much higher risk. That's something we watch very closely in their post-op course. But about 6 to 12 months later, they've developed enough neovascularization where they have a lot of protection. And so this is an example of the surgical approach. The STA is isolated, first mapped out with a Doppler on the skin. Then we cut right over it, isolate it, take off small branches, but keep it in continuity. Do the crani directly underneath it. And then see the arachnoid and PL surface and actually open the arachnoid across the sulci where we're going to lay it on. So there's direct contact of the PL surface to the artery. We sort of secure it in a position. And then I'll either open up the dura slightly differently and flip it, or tuck in the edges the other side so there's a lot of outer dura surface is actually in contact with the brain. And that'll actually induce some neovascularization from the outer dural surface. The interdural surface won't, but if you flip the outside, there's enough vascularization on the outside, will recruit with hypoxia. The two different views here, this is from Michael Scott's papers, is the carotid injection where we see that paucity of flow on A in the frontal area. And then on B, when you do the external carotid injection, you see the revascularization that has happened from the STA. So an example I like to show is a case that came in back in July. And it was a 5-year-old boy who got COVID, and as part of having COVID, he got very dehydrated, and no one knew he had a problem, but he presented with a stroke. And so this was the stroke he had. And during workup first with MRA, we see that we have moya-moya pattern on the MRA with complete cutout, most cutout of the MC on that right side. And we also usually do a CT perfusion with Dimox challenge. And we saw that on the perfusion, he did not increase his flow. He maintained it. It didn't get worse, but he maintained his flow. He did not have the normal response to the Dimox and CT perfusion challenge. So I talked a lot to the parents about surgery, that this is likely something we're going to need to operate on. And he recovered. So we kept him hydrated, put him on aspirin. He went to rehab. He initially was plegic on his left side, but again, being young, he did very well. And he now has full function. And so we then sent him for angiogram as preparation for surgery. And we see the puff of smoke. We can see the decreased flow of stenotic MCA. Again, on the lateral projection, and you see the lenticular striates being much more pronounced than normal. So then, as part of the planning for potential surgery, we then did an external carotid injection to map out the STA and looked at it as a candidate for being a donor for the bypass. And so we see very robust STA, and then we see the occipital branch of it, and there is actually already significant collateralization forming from the occipital branch of the STA. And so this is part of our team approach. We all met as a group, and after talking with our radiologist, the neurologist, the endovascular docs, myself, we decided that given the fact that we were already forming collateralization, subjecting him to the risk of surgery with the potential for stroke right now, and potentially interrupting the collateralization he has, actually put him at higher risk. So we are just going to follow him with aspirin and hydration, as he has already, it's happened slow enough for him that he is already forming significant collateralization. And so our surgery to do it would likely be counterproductive. And this is the nuance, I think, of having a team approach to it, because as the surgeon, I just want to jump in and do the surgery. But I think having the team approach, that sometimes it's better to not do it and decrease the risk, is very helpful. And so this is a different patient with moya-moya that I did about 10 years ago. And so he had significant disruption of flow on the left and had a small stroke. And so we did do the EDAS on him. And he is now 10 years out. And we can see on the left side, you can see the flow pattern coming in there laterally on the left from the bypass itself. He revascularized an area he did not have before. And he is now 10 years out and has had no more strokes, is doing normal, now 15 years old. So I'd like to thank Dr. Ajiboye for his help for these cases, as well as the angiograms. And this is my cell phone and my email. If anybody has any questions about any cases, I always love to talk about cases. Feel free to reach out and contact me. And this is the global health information for Memorial Global Health.